Thanks, Pramoda, for this Zoom account. So I think we are good to go without any breaks. So I'm looking forward to this. Good morning, everyone. The exercise that we are trying to undertake today is something which was done last week of discussing a very relevant topic, which has actually even become more relevant in the recent times with some of our colleagues who collapsed during running, often unexplained. Some questions are answered retrospectively, but then often we all are actually left guessing what really happened, and is it something that can happen to one of us? Is it something that can be prevented? So these are questions that we need to answer. So through these next few minutes that we discuss, my idea would be to talk about the various reasons why these unfortunate incidents can happen. What can we do to screen ourselves about these conditions if we can? How can we prevent it? And also, there are lots of questions related to this. We will try answering. I've already gathered the questions, but even otherwise, if you have some questions through the presentation, feel free to ask me at the end of it. The idea should be that when we finish this exercise, we are sort of better aware about our own hearts while we run and are safer than what we are now. This is the institution I represent, and proud to be back here in the faculty, and also being able to continue to run and make people run, which makes me feel good about the job that I do. What most of us would relate to these quotes is the fact that we are, in a way, have that streak of machoism. We always try to do things which are beyond physiology, and some of us feel that feeling a discomfort or pain is something which is usual part of the sport. We should take it on our stride and go ahead. Most often we are right, but sometimes this pain that you are actually feeling may not be the pain that will make you stronger, but it can kill you. So that's the reason why although we must go by these quotes which motivate us, but we must also remain cautious. Heart is a very important organ in the body. I don't think I need to emphasize on it more, but for any physical activity to happen, heart has to pump far harder than what it does normally. And that's the reason why even a very benign or innocuous looking condition in a person who's sedentary can become life-threatening in a person who's exerting. And that's the reason why we need to know more about it. And we shall try to do so as we go along. Now, coming to the definition of competitive athlete, this is from the American Society of Sports Medicine. And if you just go through the key words, you would understand that the line between a competitive professional athlete and most of us, in fact, in the recent times, has become very thin. We all try to achieve better than what we did yesterday. We are all through a systematic process, and often this training is intense, and subconsciously or otherwise, we often try outdoing the person next to us, and often that may not be the right thing to do. So the concept of sudden death or sudden cardiac death, what we call when it happens due to a probable underlying cardiac cause, is a well-known incident. And most of the big events that we see, we often at the end of it hear of these unfortunate incidents. Usually the cause when it comes to younger individuals, although it's very rare, it's less than 1 in 100,000, which is not so much, but it's often due to an inherited condition which they are born with. But when it comes to older athletes beyond this age, it's often the coronary artery disease, or what we know as ischemic heart disease or heart attacks in common parlance, is more common. But if the inherited conditions have not been detected at a younger age, they often actually can manifest in an older individual. The good thing is that these inherited conditions actually can be detected early, even when they are not producing any symptoms. And deaths can be prevented by taking appropriate precautions. And that's why this screening becomes very important. If you look at the causes of sudden cardiac death in athletes, the two major chunks that you see are of the inherited conditions that we're talking about in younger people is the coronary artery anomalies. These are arteries which supply the muscle in the heart. They originate from the main artery, which is the aorta. And in a normal situation, they would originate from the aorta and supply the heart muscle directly. But in certain abnormal coronary arteries, what happens is that either it may be originating from a different artery, not aorta, but the pulmonary artery, or it may be originating from a venous side of the circulation, which is less in oxygen, or it may be passing through an abnormal route, which is through the cardiac muscle. And thereby what happens is when the heart muscle is contracting, it can actually compress the coronary arteries and sort of cause a block, which is not seen routinely, but it would happen while the person is exerting. Now, these are one of the common groups of disorders, along with the most common, which is called the hypertrophic cardiomyopathy. This is an inherited heart muscle condition where the heart is thick, abnormally thick, and because of this, it's not able to relax properly while the blood is filling in. And also, while it pumps blood, there is a kind of an obstruction which is created in the blood going out of the heart. And this obstruction is not a fixed obstruction. This obstruction is a dynamic kind of obstruction. So in a normal level of exertion or heart rate, it may not manifest. But while the heart is pumping harder, this obstruction, the degree of this obstruction tends to increase. And these patients actually can have sudden deaths again, and often it's detected post-mortem. Then, of course, there are certain less common conditions which are related to defects in the cardiac muscle, defects in the aorta, defects in the heart valves, especially the aortic valve, which may be stenosed or narrow. There is a less common cardiomyopathy called the dilated cardiomyopathy, where the heart is thinned out and dilated and it's not able to pump adequately. And of course, there are a subset of youngsters who can have the usual coronary artery disease at a younger age, which is usually happening much later. But because of the fact that they have these risk factors from early age, like cholesterol, blood pressure, diabetes, they can actually be prone to coronary artery disease in a younger age. And in fact, this subset is gradually increasing in the recent past, with more of lifestyle disorders hitting the younger people. And of course, there's a small subset of condition called myocarditis, which here it shows as 3%. But with recent increase in viral infection, especially COVID and certain unknown viruses, myocarditis is, or the inflammation of cardiac muscle, has also become an important disease, which can affect heart function. It can affect the function, both the pumping mechanism as well as the fact that if inflamed cardiac muscle is more prone to rhythm abnormalities, and the patient can suddenly go into an arrhythmia. And this is something that has been noted in the aftermath of the COVID pandemic. So these are the various disorders that one can look at, try and screen for them, or at least suspect them when there are relevant symptoms. Coming back to the conditions which are commonly related to sudden cardiac deaths, there is an inherited cardiac condition. There may be associated mechanical abnormality or electric abnormality, like I just mentioned. And these require looking at the heart from two aspects, one being its electrical function, and two, its mechanical function. Just to actually repeat what I had just mentioned about the causes, in younger individuals being inherited disorders, and in older individuals being the coronary artery disease. And just to re-emphasize the fact that a lot of youngsters actually are coming with coronary artery disease now. You don't have anything inherited in them, except for the fact that there is a risk to develop atherosclerosis, which is the development of blocks in the coronary arteries, and that makes them more prone to dying early. This is what I meant by that commonest inherited condition called the hypertrophic cardiomyopathy, where the heart muscle is very thick and the chamber becomes narrow inside. So the volume of blood that can actually be there inside is less, and the heart is stiff, not to relax properly while the blood is filling. Both of these conditions lead to abnormal functioning of the heart. The heart is also more prone to arrhythmias in such cases. And the good thing about it is that it can actually be suspected on a routine ECG and definitely be confirmed on an echocardiography, because these are changes which cannot be missed on an echocardiography. Then there are certain other structural cardiac abnormality. I mentioned about the coronary artery being anomalous or abnormal in their origin. Then there are certain valvular abnormalities like the mitral valve prolapse or the aortic valve being stenosed or narrow. And then there is an inherited condition called Marfan syndrome, where the individual looks abnormally tall with long, the arms are long, the legs are long, and then they also are more prone to heart abnormalities. And in fact, there's a life-threatening condition called aortic dissection, which can happen in them, which is basically a rupture of the cardiac muscle extending into the aortic muscle, thereby blocking the aorta totally. And in fact, this is one of the reasons why a person of Marfan's can actually die suddenly. Marfan's is a condition which can be picked up easily by just looking at a patient and doing certain basic tests. Now, there are a subset of abnormalities which are not mechanical. Here, the problem is that the heart is more prone to arrhythmias, and there are certain abnormal pathways which connect the various pacemaker in the heart to the cardiac muscle. And also, the process of conduction of this electric stimulus in the heart may be abnormal. So there are certain conditions called pre-excitation, where the pathways are abnormal, or there are certain inherited conditions called long QT syndromes, which can actually often be silent, or the patient may just come with occasional dizziness or blackouts, or a frank syncope where the patient falls unconscious and then recovers spontaneously. There may be just an arrhythmia which settles down itself and the patient just feels a brief period of palpitation. And of course, the most sinister way it can present is by a sudden cardiac death. These can be picked up on routine ECGs, thankfully. So again, that's where the importance of screening patients with a routine ECG is. Then there are certain less common conditions where there is a structural abnormality on the ECG, I mean the structure of the various wave patterns that are seen on ECG. This can be picked up by a cardiologist who's trained to look at them. These are not something that are routinely picked up by the technicians who report on ECG, or even the machine which reports due to the various AIs that we have now. This requires somebody with a keen eye to actually look at it and pick up. Then there is a subset called catecholaminergic VT, or ventricular tachycardia. Basically, what happens is that when we stress a lot or exert, there is an increase in the amount of hormones which are called catecholamines, like the adrenaline, noradrenaline. And while this patient may have a normal resting ECG, while he's on an exercise mode or on a treadmill, this patient may develop an arrhythmia. Now, this can be picked up on a treadmill test, but can be missed on a normal resting ECG. Now, what is more common beyond the age of 35, 40 is the acquired abnormalities. It may happen in younger people as premature because of familial hyperlipidemias, which are also common. You do find younger people having high cholesterol levels. This can also be picked up from history of the patient if there are relatives, especially first-degree relatives who've had a heart attack in young, who've died young, unexplained, before 50 years of age. Then, of course, there are, I mentioned about myocarditis being a relevant condition now. And of course, the lifestyle disorders, which are definitely a big issue. A lot of young people are coming with hypertension and diabetes, which make them prone to heart diseases at a much younger age. This I've already discussed, so I will not go too much into it, but suffice to say that it's one of the commoner reasons why suddenly people collapse unexplained. And the way it can be picked up is by echocardiography done by a person who's actually looking for it. Now, I'll keep on repeating this fact because routine echocardiography for a person done in clinical practice looks at certain things. But if the cardiologist has to look for cardiac abnormality in a person who's going to exert like we runners and otherwise has no issues, these are certain aspects that one has to specifically look for. And that's the reason why the person who's doing the echocardiography to be trained on this and with a keen eye. Sometimes it can be missed, or if it is suspected for confirmation, may require CT angiography, which is basically a CT scan where a dye is injected, and you can visualize the coronary arteries well. I'll show you a few images of that. And it's something which can be corrected surgically. So if it's picked up early and corrected, actually may be life-saving. Now, an aspect of disease which is we may not be born with or be prone to because of our various risk factors, but we may be prone because we are exerting beyond physiology. What happens when we exert to the extent that we usually do is that there is a reversible amount of cardiac muscle injury that happens all the time, every time we exert, more so when we do it at the level of marathon. But this is something that recovers gradually, and then the heart becomes stronger and more conditioned. And that's the green curve that you can see on this. That's a good thing that we are actually putting our heart into. Now, if the person is overtraining or the recovery is inadequate, the repeated exercise insult that is happening to the heart is so much that the heart cannot take, or there is an additional risk factor which is already there and you are putting this heart into greater stress, this cardiac injury may not recover well and may keep on accumulating over years and lead to a state of something similar to what happens in a cardiomyopathy. So the heart becomes thicker, more fibrosed, less relaxing, or sort of more stiff. And also because of various, it's like scarring the heart again and again. And this cumulative injury can actually make heart prone to arrhythmias as well. So it's both mechanical as well as electrical abnormalities induced by repeated exercise insult to the heart. Now, this is something which may not be there earlier, but over a period of time can be picked up on a serial echocardiography and ECG. So this is one reason why when towards the end of my talk, when I talk about recommendations to screen, I think in our case becomes more relevant of the reason for periodic screening of our heart, even if it's normal to begin with. So this is what the slides on explaining why this happens in stress. So while training systematically and recovering well may be a good way to condition your heart, but if you do it or you overdo it, you tend to put the heart muscle at damage, and there is a long-term cumulative damage that can occur and lead to abnormalities. I think that much of knowledge of underlying heart problems which can come with symptoms or may make you prone to collapse while exerting is, I think, enough for us to know. So what I've done is I have actually put in a few slides on what we need to do to screen, and this protocol may be of benefit to us. History is very important. Every person has to sort of answer a few questions and also notice these symptoms which are happening. Classical pain of the cardiac disease, everybody is aware. It's a mid-chest pain. It's called angina. It comes on with exertion, gets relieved when the patient takes rest. There is associated sweating, palpitation, or feeling of doom kind of a feeling, and something which cannot be explained easily because it's not related to one particular point of pain. It's more like a discomfort often. It can sometimes come without pain. It can just be a dizziness, blackout, sometimes a near blackout or a total collapse and then recovery. They can just be episodes of palpitation which come and go, or the blood pressure rising far beyond the usual while exerting, or being picked up on examination. There is also associated history of risk factors that one needs to take, like smoking, the presence of diabetes and hypertension, and of course, very important is the fact is about family history, because that is something which will point towards an underlying condition in you which you are not aware of, especially in younger people. Just history of unexplained deaths in first degree relatives itself is a risk factor, because most likely it's due to a cardiac issue. And of course, if you know that there are certain known cardiac conditions in the family, then there's no doubt. Like, for example, hypertrophic cardiomyopathy is a condition which is transmitted in every generation. It's autosomal dominant condition. So if there is an abnormality in the family, then you are very likely to have it, and one needs to screen. This is a risk score which is very common. It's easily available on the net. In fact, I have just put a slide last time. There was a lot of confusion on this about the risk score. It just looks at your gender, whether you're a smoker or not, what's your total cholesterol, your HDL levels, which is the good cholesterol, your blood pressure, and whether are you on treatment for your blood pressure. So what it assesses your risk for developing, and of course the age, and it assesses your risk of developing a heart attack or dying due to heart disease over 10-year period. And so this is something which has been well validated, and risk beyond 10% is significant, and because that's the average 10-year risk in population. And so anything beyond 10 years is 10% is not good, and beyond 20% becomes very significant, and one needs to undergo various tests. So this is something I would advise all of us to actually go through. Most of us would actually fit into a low risk. That's a good thing, but it's worthwhile knowing what's your risk. Then, of course, the examination part of it, some of it we can do ourselves, like the anthropometry, height, weight, BMI, waist circumference. This is very important, although most of us are fit and may not be healthy. Having a larger waist circumference or being overweight and obese, although we may be running regularly and doing all kinds of fitness activities, puts us at a risk because of the fact that this is a metabolic abnormality. Then, of course, the resting heart rate, which gives us an indication of how well conditioned our heart is, and also tells us about our state of recovery. Measuring or looking at the pulses in both upper limbs and lower limbs, or whether there's a asymmetry in both the limbs. It also points towards certain conditions which may be inherent, that you're born with, like abnormality of the aorta, called the coarctation of aorta. There may be some blockage due to atherosclerosis, which can come on later, which can be picked up by just looking at the pulses if they're asymmetrical. This is something that the doctors will do. On our own, we cannot do it. That's about testing. The doctors would probably examine you further more in detail, looking at your heart. But these are tests which routinely may be done as a screening. Some of them are essential. So two major metabolic aspects are the cholesterol and the sugars. This puts you directly at a greater risk of having heart disease. And this is something that should be routinely done at least annually. The other way of looking at the heart, which although not a routine test for medical checkups, but for us runners becomes very important. Now, one is ECG, and two, ECG done while you are under stress, like the treadmill, and two, looking at the structure of the heart, which is echocardiography. Now, these two tests, although if you look at the guidelines, even for athletes, is mentioned as a test to be done optionally in case the person has a risk or is symptomatic with certain symptoms that I mentioned, or has some abnormality on the resting ECG. These are not routinely done, even in athletes. But we should remember that most of us, in fact, are at an age where we are at greater risk. For a population recommendation, it may be valid that the government doesn't want to these associations don't want the whole population to be screened. It's a major exercise, the cost is involved, and the benefit of preventing deaths may not be so much as much as the various risks of testing, that is picking up false positives and increasing the cost of healthcare and all that. But on an individual basis, when we are discussing for a small group like ours, and runners who are at an older age, most of us who have started running at an older age, so we actually have not put our hearts to the kind of stress that may have picked these conditions much earlier. It's actually very prudent to do these on an annual basis and exclude them before we get into the process of getting into serious training. And of course, based on this, if there are certain abnormalities, if the doctor suggests, then certain tests may be required, like CT angiography or coronary angiography, or there are certain other tests which routinely need not be done. This I've already spoken of about the ECG. This actually is very important. Looks like a very simple test, but this printout actually, if looked at seriously, can tell us a lot of things. And of course, the echocardiogram is nothing, it's just an ultrasound of the heart, and done in a way to look at all the chambers in the heart, look at the valves, whether they are functioning properly, the origin of the coronary arteries, the origin of the large arteries, that is the aorta and the pulmonary artery. And also, there is a way to look at the flow by Doppler. It tells you how the blood is flowing. Is there an obstruction? Is the pressure high? So the pressure can be recorded. So all these, it's a very, very sophisticated way of looking at the heart, very non-invasively. So somebody who's trained at looking at those subtle changes that can pick up the risk of developing a problem while you run should be doing this. This is the CT angiography. This is like a CT scan done after injecting a dye, which would make the arteries visible on the scan. And this is a 3D reconstruction, which will actually show those arteries and the course of the artery and if there's any obstruction. In a person who is at an intermediate risk or a high risk, this may show certain abnormalities, and then those abnormalities will require confirmation by the conventional angiography, where the dye is injected and a person is put through. That's a dynamic process where a wire is put inside and seen under a fluoroscope. However, if the coronary arteries look absolutely clean, normal on this CT angiography, it sort of rules out a significant obstruction. So it does sort of exclude an underlying serious coronary block, but it may show certain abnormalities which would need confirmation. So that's the problem with CT angiography when it is done in people who are asymptomatic and who do not have any great risk of having coronary artery disease. That's why routinely it's not to be done just as a screening tool, although some people actually go ahead and get it done also, and then are wondering with that block what happens. They become sleepless. And unless you do a conventional angiogram, you can never be sure whether it is actually a block or not. So the certain points that one should remember is that the most important thing is symptom. If you have a symptom which can point towards heart disease, should not be ignored, because we are actually looking at screening before symptoms appear. But once symptoms are there, they should never be ignored. Even vague symptoms, which may not be classical of heart disease, but if they are recurring with exertion, they should not be ignored. Now, these vague symptoms may be something like related to your abdomen. You feel burning sensation in your abdomen, or you feel that sense of indigestion or bloating. Every time you exert, it happens and it goes away while you are okay. So these things may be passed off as acidity or something you ate yesterday, but often may be related to the heart problem. Maybe just a pain in your shoulder, pain in your jaw, and you will feel that it's related to my teeth. But if it comes on with exertion and goes away, it is not due to your teeth. It's probably something more sinister. Then, of course, very important thing that we need to remember is that sense of undue fatigue or chest discomfort, which comes on with an exertion which normally you were doing regularly. So anything that makes you feel that you're not up to it, and this is happening again and again, it tells you that you need to back off. And unless you get properly tested and you're sure to be fit, don't exert to that extent. Because often we hear from people who collapse during these events, either from them subsequently, or if it's unfortunate, then some friends of theirs would tell you that he was having these symptoms earlier as well, and probably was ignoring. So at least in some of them, we do get this history. So this is something that we need to remember. And of course, the straightforward basics that we should avoid smoking. Even a little degree of smoking is bad. Excessive alcohol, of course, and adequate sleep. There's no going away from the fact that the best form of recovery is sleep, whatever else you may do. And keeping weight and your abdominal obesity under check is very important. We all have this feeling that since we run, we exert so much, we can eat whatever, we can be okay, slightly overweight, but there are certain metabolic risks which cannot be outdone by our exercise, what we do. So, and that's to do with the way we eat, we sleep, or we live, which we should keep it at a healthy range. Of course, regular monitoring of blood pressure, resting pulse rate, as I already mentioned. Screening tests that we spoke about, we'll again repeat later. And of course, repeat tests annually or as advised. If there's an abnormality, it may require a repeat earlier than that. So till now, I've actually tried and go through all the important indications where one would have to screen, the reasons why one would have to screen. 2, what are the symptoms that one should seriously look for? And 3, what are the ways we can actually look for these abnormalities and pick them up? I think this covers broadly all the abnormalities that one can face. I will now go through a certain question and answers that I've actually gathered over the last 2 presentations that we've done on this. And some questions have got added in this present exercise. So I'll go through them and then we'll take on the questions from the audience. I hope. Yeah.
So, before you proceed, if I may just request you to just re-emphasize the concept of resting pulse rate, because a lot of them are non-doctors, non-runners, also on the group, before you go into the Q&As.
Yeah, okay. So any of the non-doctors and non-runners, is there anything that you are specifically looking at from resting heart rate? Any doubts? So I can hear some kind of a sound which looks like a echocardiography Doppler. Okay, so the resting heart rate is most of us who wear smartwatches or Garmin would actually have this on our watch. Otherwise, the best way to do it is that when you wake up, before you get out of the bed, you measure your pulse for at least 30 seconds and make it out of a minute. The value is not important in absolute sense because all of us would have a different resting heart rate depending on how well conditioned our heart is, but definitely lower the better. But it definitely gives us a good indication of how well rested we are, because if you're waking up with a heart rate which is more than your usual resting heart rate, even up to say 5 beats per minute, it actually points towards poor recovery or the fact that you may not have had adequate sleep, or the party that you attended last night was a bit too much. So it's very important as an indicator, should not be ignored, because if you go ahead and feel good still and start exercising at the way you are normally used to do on that morning, you may or may not perform as well as you expected to. But even if you do that, you may have actually put your heart at greater stress, and we spoke about that earlier. So resting heart rate is actually telling you that you are still in that green curve of good response to exercise as far as cardiac muscle is concerned. Poor resting heart rate points towards that red curve, and that heart is actually getting cumulatively damaged. So that's the relevance of resting heart rate. We'll answer some questions on it later if they crop up. Coming to the questions, how much weightage to be given to genetics, family member, and heart issue? I think I did mention it. It's the component of risk which is inherited is far more than what we think. At least in most of the conditions, even related to lifestyle issues like obesity or blood pressure and diabetes, it's almost 60 to 70% contribution comes from your genes. And these are some things that you cannot do much about, but you can at least pick it up from your history, from your family members, and also by doing certain tests which can tell you that, like for example, abnormal lipid profile in a young person is usually an inherited condition. So definitely there is a lot of weightage, and that's the role of taking proper family history of sudden cardiac deaths in the family, sudden unexplained deaths in the family, or history of strokes or heart disease in the family at a younger age, that is less than 50 years of age. 2, are runners asymptomatic to heart conditions, and are the first symptoms, if and when they occur, fatal? Definitely the runners are not different from others when it comes to symptoms of heart disease. Most of the heart diseases will produce some kind of symptoms which may be subtle, which may be frank, but yes, there are a lot of heart conditions which may actually be asymptomatic till the time they manifest as sudden cardiac death, and that is something that may apply both to runners as well as non-runners. But definitely runners have, or any sportsman to that effect, have this feeling of ignoring their symptoms, or maybe it's that endorphin that takes over while you're exerting, and you feel that okay, you may just sort of run through this symptom. So that may be one of the reasons, but otherwise I don't think runners are any different from others when it comes to symptoms related to heart disease. I've already gone through these symptoms, but I'll just repeat that there are certain symptoms which are not related to chest. So to say that chest pain is the only symptom of heart may not be true. The pain may be below the chest in the abdomen. It can also be above the chest, say the shoulder, the jaw, and radiating up towards the ears. So these are, but what's important to remember is that if a symptom is unusual, has appeared while you are exerting, or has gotten worse while you exert, it's something that should be seriously looked at, irrespective of which part of your body it's coming from. Right. So that's very important because it may be related to heart. Then, of course, there are certain symptoms that you should not ignore, which are classic now scientifically known to be related to heart. So there's no reason to be ignored. And these are the red flags: chest pain, or just a feeling of some pressure on the chest, the radiation to jaw, neck, or shoulder, unusual sweating in a setting where you may not be, it may not be that warm, or coming on without exertion, or a cold sweat kind of. Abdomen symptoms I mentioned, intense fatigue, lightheadedness or dizziness. Sometimes it's just an impending doom. In fact, it's like an odd symptom which patients often come to us saying that kuch acha nahi lag raha, which itself actually makes us, especially in patients who are slightly older, we always do an ECG because sometimes the heart presents with things which are unexplained. And although it sounds very dramatic, but it does happen often. Now, are heart problems the only cause of untimely death, or can it be brain strokes too? And are those related? Now, yes, heart problems are the only cause of untimely death in the routine settings, and strokes by themselves actually do not kill a person immediately. It takes time for the brain to be damaged and then cause a death. But yes, if there is a intracerebral hemorrhage or bleeding inside the brain, to an extent that is increasing the pressures so high inside the skull that is incompatible with life, yes, the person can die immediately. But even then, usually these situations are not without symptoms. So they do give far more symptoms than sudden death due to cardiac condition. So that's true. And yes, they are related because both are vascular diseases. Both are related to the arteries, and the causes are usually common because while there can be a block in the coronary artery, similarly, there can be a block in the cerebral arteries. And in fact, they are put together in the coronary heart. The various heart disease risk scores include both the heart problems as well as stroke. And of course, even hemorrhages in the brain are related mostly to hypertension or abnormal vessels, which again are directly or indirectly related to heart diseases. How do we look out for clotting? Now, in the body, where the abnormal clotting can usually be found, and it may be innocuous to start with, is the clotting of the veins in the leg, which is called deep vein thrombosis, which usually happens in the calves. And this can be suspected in a person who has a sudden pain in the calf or swelling in the calf, which is unexplained, or appearance of prominent veins in the calf. Sometimes it can be pain along with redness, and it looks like inflammation, but it may be a block in the veins in the calf. So this is a pointer towards abnormal clotting, but this clotting can happen in any part of the body and may require tests to find out. But deep venous thrombosis of the calves is something which can be sort of examined and diagnosed. Any role of electrolyte imbalance in sudden deaths? Yes, definitely. Arrhythmias are known to occur in situations where potassium is abnormal, and especially low potassium or hypokalemia can lead to these kind of arrhythmias like ventricular tachycardia or fibrillation and cardiac arrest. But sodium abnormalities, although does not cause cardiac arrhythmia, but hyponatremia actually can cause dizziness and altered sensorium and even coma, and go on to cause death. Or hypernatremia, which is a sign of dehydration or thickening of blood, if you can look at it that way, makes one more prone to clotting and lead to strokes or heart attack. So again, in some ways, electrolyte may either be a sort of a marker of an abnormality which can lead to cardiac death or sudden death related to strokes, or it may just be a sort of forewarning that you need to correct it before it can actually present in a more sinister way. Now, this is something that we all have heard recently and we have observed as doctors. Yes, definitely we do see more of younger people coming with heart attacks, strokes now than before 2021. And because the biggest thing that has changed in the recent past is the appearance of this pandemic, there is definitely a sort of looking at association between the two events. To some extent, yes, COVID has made people prone to blood clotting, and hence we do believe that it may be related. Even the severe COVID illness affecting the lungs had shown increased blood clotting, and that's why we were using anticoagulants like heparin while treating these patients. So yes, it does make one prone. The other way it affects is, like I already mentioned, was about myocarditis or inflammation of cardiac muscle, which makes it less effective as a pump or makes it more prone to arrhythmia. So COVID definitely has an impact on heart, which one needs to look out for. And that's the reason why we always advise that however mild your disease or your symptoms related to COVID may have been, you need to start off gradually after you recover and look definitely undergo basic tests to screen before you restart training again, and then take it on gradually and sort of listen to your body while you exert. This was a question which is related, which I think I have already covered. This was a specific question related to one runner, so I'll not repeat it here. This is something which most of us have been asking sometime or the other, and I've heard this question quite often, that some days when I exert, my heart rate is okay. Some days it really goes high, although I don't feel so bad. I still feel comfortable, but my heart rate is going high. Most often our devices are very reliable. It's not so bad, especially even the new wristwatches give a fairly reliable heart rate. So resting heart rate I've already covered, but on exertion, if you feel that your heart rate is going beyond the usual, and although you're feeling okay, do not ignore that symptom, especially if it is happening repeatedly, because it may be telling you something which you're not feeling, which often happens. The heart may actually be suffering far earlier than what your brain is telling you. So it's good to actually not ignore it and sort of get tested. Abnormal response or tachycardia on exertion, which is submaximal, may also be a sign of heart being abnormal. So do not ignore that. This is again.
Sir, one small question on the heart rate.
Yeah.
What
Yeah.
is the general percentage of increase which is treated as acceptable from resting to exertion?
See, one is the fact that it is relative to your usual exertion. So if you are and it's also related to your maximum heart rate, which is approximation is 220 minus age. So when we are going by those heart rate zones, if you are exerting at a pace which is likely to be your aerobic or threshold pace, if your heart rate is beyond 80% of your maximum, that means your exertion may be feeling like aerobic, but your heart is working at a far beyond the threshold pace. And that, again, it's not a specific number that I can say, but it's relative to your own paces or heart rate that you were achieving earlier. Two, if you are not having those zones or otherwise, if you are if you look at your breathing or perceived exertion that you feel, and so you can correlate that to your heart rate as well. So if it is beyond what you usually feel at that pace that you're exerting, I think that also is enough. But specifically, if you ask me what number, how much, I don't think that's would be written anywhere. It's very variable. So that's all I would say. If it also depends on the weather that day, it also depends on the gradients. So putting all that or correcting for all that, if your heart rate is going beyond your exertion, then definitely you need to take it seriously.
I have a question on this line. I mean, related to having higher heart rate during the training. So generally, so the thing happens is, okay, we know that 220 minus age is your maximum heart rate. So let's say if it is 180 or 186 is our maximum allowed heart rate. But still, so whenever we are training, sometimes the heart rate goes really high. And let's say if we are training in a zone 4 or zone 5, the heart rate is supposed to go high. So how do we know that whether, like, I mean, definitely if we're pushing at a certain pace, it is not supposed, I mean, it is not going to be in a comfortable zone. Let's say if I try to push at a 4 pace, it's definitely not going to be comfortable. How would I know that? So whether it is giving me a sign with being a higher heart rate, or it is just me pushing and then my body can just take it. Like how do I know that, there is a very thin line between this, that am I pushing my body or my heart is giving me some sign that something is abnormal?
Yeah, I got your question. So that's why this calculation of maximum heart rate by 220 minus age is actually an approximation. It doesn't apply to everyone in the way that it should. And that's where the role of undergoing a stress test comes. When you run on a treadmill and your heart rate goes up, with the ECG changes that are picked up while you're running, you get and there's a protocol that's followed while you are on the treadmill by the cardiologist. And this will put you through exertion, and looking at the ECG will take you to a heart rate which may be beyond your 220 minus age. For a simple reason is that, say, for example, if you're 40 years old, and so all 40-year-old have a maximum heart rate of 180 as per that formula, but not all of them will behave similarly at 180 per minute. So that is something which can be picked up on a stress test, where the maximum heart rate that is calculated there becomes sort of more relevant indicator for people like us, who quite a few times you must have heard people who say that I sort of run and my heart rate goes to 180, 190, but I don't feel anything. So if you've undergone a stress test, if you've seen your heart rate there along with your ECG, that shows that, okay, although as per your formula you are overexerting, but as per your heart, actually you're not. So that's the reason why I again emphasize on the fact that going through a treadmill test is very important for all of us to assess actually how the heart is behaving.
Okay. And it is sometimes so there are a lot of people saying that in general the heart rate is fine at a particular in a particular distance or a pace, but few days the heart rate goes really high. So could it be a factor of weather or something? And every time this happens, let's say once in a month the heart rate goes really high. So should we get a test done every time when it goes high?
No, definitely not. See, that's why I said there are certain variables that you need to look at, like weather, what is the state of hydration? Because again, if your hydration, in fact, there's a question later on that, if your hydration is not adequate, your blood volumes are not enough, then your heart ends up actually exerting more. If the core temperature of the body goes higher because you've not cooled properly or hydrated properly, again it goes higher. Or if you're sweating more. Similarly, if especially for women, certain periods of your menstrual cycle, the hormone changes are such that your heart otherwise also is beating at a faster rate. So you tend to actually exert, and your thermoregulation is also impaired to some extent, or the temperature regulation. So your heart rates during those days, or during those weather conditions, or your hydration status, or your sleep status may actually be slightly different. So those are indicators that you sort of take it easy on those days instead of going ahead and exerting despite all that. But doesn't mean that you need to land up with the cardiologist every month and say that aaj mera heart rate zyada ho gaya. No need to panic. It's all, so that's why there is a reason to compare it to your usual. Try and explain it by the variables that are around you. Step back on those days, and then when those variables are addressed, exert again and see what happens. And despite all that addressed, if your heart rate is not behaving, or your the feeling of fatigue is not improving, then that's something to be assessed. So that would happen less commonly.
Okay, got it. Okay. Thank you so much, doctor.
Yeah, sure. The bundle branch block, this is one of the ECG abnormalities. There is a right bundle branch block or left bundle branch block. This can be picked up on the routine ECG by a person who's trained to look at it. These are blocks which basically tell you that the conduction system in your heart is abnormal. Now, right bundle branch block is a very common occurrence even in normal people. So it may actually not be harmful, especially if it has been there from before. If it has appeared suddenly, then it's not a good thing, that it needs to be worked up. But if it's been always there, it actually may not be an abnormality. But the thing is, one should know, because every time you do an ECG, somebody is going to point it out to you. So it's definitely not harmful. And having RBBB doesn't make you more prone to any disease. But whoever reads that ECG has to be tuned to see certain other changes which can actually pick up an abnormality which is rare, called Brugada syndrome, where the RBBB may be there, and that abnormality makes you sort of a greater risk to develop an arrhythmia. This we've already discussed about the lipid profile. Cholesterol, triglyceride, and cholesterol has various components, LDL, HDL. One is bad cholesterol, HDL is good cholesterol. So all those factors, and triglyceride is something which is most commonly affected by your day-to-day diet. And even if you've not given your sample fasting, it will be high, or your alcohol consumption, or how much sweet or sugars you've eaten the previous day. So all these factors actually tell you that you are at a greater risk for metabolic abnormality, which leads to formation of atherosclerosis, or the plaques in the coronary arteries, which make you prone to either heart problems or strokes. Now, what are the tests need to be taken? Now, some people specifically asked for these tests, which till now I have not mentioned, was the CT calcium score, which is basically a kind of a result which can be done on a CT scan of the heart, like we do CT angiography. Before injecting the dye into the coronaries, we can actually on the CT scan, it shows those calcifications on the plaque, and that is an indirect marker of plaques in the coronaries. So that's sort of a screening tool. It's been used in certain settings, not routinely done, but when CT angiography is done, this calcium score is also reported, and it can add to your risk of having a block. 2D echocardiography I've already mentioned. Arrhythmias, any screening to be done? Yes, routine ECG and a treadmill test where ECG is recorded are the two common tools. In certain patients where the cardiologist suspects that there could be an arrhythmia which is being missed, he can put you through a long-term ECG, which is called the Holter monitoring, or a loop recorder, which will record your ECG over a few days, and there's some transient arrhythmias can be picked up. This was a question last time about how important is CPR or cardiopulmonary resuscitation in the first few minutes, or what we call as cardiac massage, after a person has collapsed. Yes, it's very important because the brain cannot tolerate lack of blood supply for even few minutes. So how well you may revive the heart after a few minutes, but the damage to the brain may persist and the person may remain sort of bedridden. So it does have a very and two, also the fact that the faster you revive a person, the better chance he has of actually coming back, the heart coming back. The longer it takes, there is less likelihood of resuscitation being successful. Now, about genders, yes, the risk factors are same, but nature designed in such a way that females are protected in a younger age, basically due to their hormones, especially estrogen. So they are at a lesser risk for heart diseases at a younger age, but when they cross menopause, they are at an equal risk as a male. The other thing that I want to mention here is that over a period of time, the lifestyle factors and the acquired factors like all these viruses, things like that, have added to our risk. So even in women, we see heart problems occurring at a younger age, even when their estrogen levels are adequate. So no longer is it true that like normally earlier, we would never diagnose heart attacks as a cause of chest pain in a female before menopause. That was what was in common knowledge when we were training. And now we see women at a much younger age coming with heart attacks, which is not so uncommon. So basically, lifestyle, inherited cholesterol problems, or these viruses, all these have actually undone a lot of good that estrogen can do. So we must take it seriously. The symptoms should be taken seriously in both men and women. Low body fat percent, is it a cardiac risk? Not exactly. None of us is in that low. The problem is always a higher fat percentage. Low or abnormally low fat percentage in single digits may actually affect the adrenal gland very commonly, because of the fact that some amount of fat is required to produce various important hormones in the body. And these hormones actually can affect the way our heart functions or our brain functions. And that's the reason why a very low body fat percentage may be a problem. But I don't think any of us has that issue as a major cause for worry. Dehydration, as I mentioned earlier, yes, it can predispose one to developing cardiac arrhythmias or clots, basically because the blood becomes thicker. And also dehydration is associated with electrolyte abnormalities, which can make one prone to rhythm abnormalities. So, thirdly, the dehydration makes the heart having to pump harder because the volume of blood becomes less and it becomes thicker. So even a change which is subtle can become more prominent because the heart has to exert more. So yes, dehydration is something that one should be sort of avoiding. This, I think, this point we have already covered. I won't repeat this. So I just want to conclude by saying that fitness always doesn't mean being healthy. So we should try and take it seriously when it comes to looking at various health parameters and getting screened for things which can actually be harmful. We should not ignore the basics of sleep, recovery, good warm-up and cool down, and gradual progression, and most important is smart withdrawal when things are going wrong is very important. And definitely saying that again, don't overlook the unusual symptoms, especially if they are coming back again and again. So while we may train or peak for a certain race, I think we all should aim to keep running for as long as possible. And to do that in a healthy way, I think, and to survive, I think we need to follow these basics and get screened at the right time. I think that's all I want to say, and I hope we've gained something out of this. Is there any further questions? I would love to.
Yeah, I have. I had put up one question on chat. Is there a checklist which we can have, which we can take to a doc and say, you know what, these are the things that we need to specifically check for? You know, we don't want that the doc will, you know, might forget. I have a chance of forgetting that. Oh, I didn't just check that. So can we have kind of a checklist?
Checklist in the sense, see, often we should go to a doctor who's tuned to this subset of patients, because not all cardiologists deal with sportsmen. So, but every city would have somebody like that, and a running group would know somebody like that. That is one. And two, I agree, we can actually, so I'll share with you, I have mentioned a few things in passing, but maybe it was not so clear. So ECGs, so looking at presence of chamber enlargement or left ventricular hypertrophy, as we call it, which can pick up the cardiomyopathy, or the ECG abnormality of conduction blocks, or QT interval, or the bundle branch blocks. Now, these are basics which every cardiologist will look at on the ECG. Unfortunately, what happens is that most of the time, the ECGs are reported by the machine, and echoes are done by technicians. Cardiologists themselves would just, and the technicians are usually well trained, but they are trained to look at the basic parameters. They may not be looking at it with the point of view of an athlete. So if the cardiologist is told the same thing, he can go through the same parameters and tell you. And if he suspects, he can actually repeat that echo. So on echo, he can confirm whether there is a presence of hypertrophic cardiomyopathy. He can actually look at it seriously and see if there is, cautiously, if you look at the echo done properly, you can pick up those abnormal coronary artery origin as well. On stress test, these things become more prominent. So presence of any ECG change or arrhythmia while the stress test is going on also points towards these abnormalities. So there is a specific, there are a few conditions. So all the conditions that I mentioned have changes on either ECG or changes on echocardiography, or something that will come up during a treadmill test, which cardiologist would know if you tell him that the reason why you're getting this test done is purely because you're going to exert at this level. So, for example, one of us underwent a treadmill test recently, and the test was submaximal. Submaximal in the sense that the protocol was followed, but that's the protocol we follow routinely for a person in a normal kind of executive health checkup that goes on. Now, if you tell him that I am going to exert like for running a marathon, or I'm going to sprint at this pace, and my heart rate usually goes up this much. Now, if he is done a submaximal test, he would actually put you through a maximal test, look at your maximum heart rate during your treadmill, and then say that despite reaching there, your ECG was okay. So that's that small gap on the top, which is required for people like us. It's not required routinely. So that is a sort of a gap which can be addressed if you tell the cardiologist initially why you're getting it done.
Got it. Thanks.
Yeah.
I have a question, doctor.
Yeah.
Hello.
Yeah. I'm here.
Yeah. So I just wanted to know, would running with the right form and technique reduce the risk of a heart-related condition or a death? Because obviously you would run more efficiently, breathe better if you run with the right form, technique, etc. So how is there any correlation? I mean, do you think that is important?
Yeah, see, indirectly, yes, it is important. If you're running more efficiently, you are running with greater economy, then despite that performance that you're able to achieve, your heart is not put at a greater stress. But to say that I am running with a good form, or I have a coach who's the best in the country, so I'm immune to heart problems, is not true. So yes, we all must actually follow that good form and running economy and things like that. It will help our hearts exert less for the same degree of performance. But despite all that, we should still be looking at the various risks and screening.
All right. Thank you.
Yeah, doctor, you mentioned about the CT angiography, so how often should we get the CT angiography test done, and should we advise all the runners, and specifically those who are exerting, running a marathon or an ultra marathon? So should we advise everyone to get this test done?
No, definitely not. CT angiography is not a routine test. It's only a test to be done when there is something abnormal detected either on your symptoms, or that is on your history, or on your ECG resting or treadmill ECG and echo. It's only after that, when you suspect that there is a block in the coronaries, comparing the two way of testing, the CT angio versus the conventional angiogram, they have certain pluses and minuses. So depending on the abnormalities that have been picked up, or a suspicion that has been picked up on the earlier tests, the cardiologist may advise. But as a routine for a low risk or an asymptomatic person to undergo CT angiography is not the correct way to do it. You may actually end up with a report which you will not know what to do with. And I want to repeat this again, because I think in the recent news, it had been prescribed by one of the very well-known cardiac surgeons, who's not a cardiologist, he's a surgeon. And in fact, he said everybody should undergo a CT angio, which is not correct. Should not be done. There are articles and there are studies to show that it should not be done as a routine. So I hope my answer is clear.
Dr. Muthu,
Yeah.
This is Arvind. Couple of questions. One is about ECG, right? Most of the time when we get the ECG done, we are not really exerting, right? And so I'm not sure how effective, and when we are exert, at the time the ECG, normally we don't get it. So do you see these smartwatches which have this ECG feature, as well as these modern heart rate monitors that the Frontier X, etc., which has a real-time ECG, they being more helpful? And should all the runners learn to read ECG? What is your views on that?
I agree with you that resting ECG may not pick up things which happen on exertion, but then there are certain changes on resting ECG which can help us tell that that there is a risk underlying, and some further tests can be done. So resting ECG has its own value, but yes, in addition to that, you need to do exertion ECG on exertion, which is the treadmill, and that's not an exertion that we routinely do. It's a standardized form of exertion which is based on a protocol, and it's a graded exercise, so it can be picked up on those, and it can be interpretations can be done. Now, ECGs which are coming out of that watches, I'm actually not sure. I have not seen that part of it, and I don't know how it interprets. But most of these devices are based on AI they will point out certain abnormalities which are based on whatever is data fed to them. So again, you would have to go back to a cardiologist and undergo a treadmill test to confirm whatever is picked up on your watch. So, so to start with itself, if we as a runner get screened by a treadmill test, it would be relevant. Subsequently, to follow up, we can actually just do a resting ECG and echocardiography and undergo a treadmill test if suggested before. But otherwise, I think learning how to read ECG by all runners who are non-doctors, I don't think that's worth the effort. Leave that to us. We'll go out of jobs otherwise.
Yeah. So one question on the overtraining, and you mentioned about that can lead to conditions like HCM, right?
No. HCM is an inherent inborn condition. Overtraining leads to athlete's heart, which can be an abnormal condition.
Okay, so now the question there was, I mean, typically we do identify overtraining based on, say, fatigue and recovery, etc., right? Is there the same indicators, or are there any other tests or markers which can help understand we going into such condition where the heart muscles are getting harder, bigger, whatever the...
Yeah, so there overtraining on a regular basis can be picked up on heart rate or feeling of fatigue and all that. But in what way has it affected the heart will need to be picked up on ECG and echo. ECG will tell you about the electrical changes, and the echo will tell you about the way the cardiac muscle has changed and how the pumping mechanism or the relaxing mechanism has changed. So that's the reason why even if your echocardiography is normal to begin with, so that has excluded hypertrophic cardiomyopathy or inborn conditions. But on a regular basis, getting echocardiography tells you how the heart is changing with exercise. There are some changes which are physiological, which would happen in any athlete, but then there are certain changes which are abnormal, which will be picked up on the periodic echocardiography that one undergoes. And that's why annual echocardiography, now the fact that it's easily available and not so expensive, I think will pick up these changes which occur over time. So,
and what about a marathon training cycle? I mean, typically we have, say, 14-week cycle.
Yeah, so during the cycle, it doesn't make any sense, because if you have assessed yourself before you got into that training cycle, and there are changes, because there definitely would be change while you exert. There are cardiac markers which you can do, which are done during a heart attack. Same cardiac markers if you do during exercise or just after a marathon, you will have positivity on that, because definitely there is a cardiac muscle damage. There is no doubt about it. Like your muscles in the leg get sore, similarly the muscle in the heart also gets sore. It doesn't pain there, but it does bring up those chemicals into the blood, and it can be tested. You cannot avoid that. It will happen because the heart has to exert more than usual. But heart recovers from that. There's no problem. And the recovery doesn't damage it. But overexerting on a regular basis, if you are picking up with your subtle changes like heart rate and all, and after that cardiac cycle, the exertion cycle, or just before getting into training again, because the heart recovery also would take time, you need to give it time to recover. And then you undergo an assessment again. Say, for example, in a month of March or April, if you've undergone an echocardiography, then you trained and you ran all your events in the end of the year. And then you recovered over the next few months and then did again in March, April in the next year. It will tell you how your heart has changed over the last season. And that's good enough to tell you.
Okay, cool. Yeah. And one last question, if I can. So heart rate variability, I mean, increasingly, I'm reading that that is more a better indicator of recovery and better indicator of understanding, the electrical function of the heart. Is that true, or do you see that?
Yeah, definitely. That's a marker which was known earlier also. It's just that it required a more sophisticated test to pick it up. Now it can be easily picked up on devices. It's a marker of how your brain is working while it's controlling the heart. So what's called the autonomic nervous system, the parasympathetic and sympathetic, and it picks up. So normally there is a variability. The change in this variability points towards subtle change in this system. and what is called the cardiac autonomic neuropathy. This actually can be a early reason for arrhythmias to occur. So heart rate variability is definitely an important marker which can pick up that risk or any damage that's occurring. Similarly, diabetes affects autonomic neuropathy, autonomic nerves, especially cardiac autonomic neuropathy. So again, HRV is a good marker there as well. So yes, it's an important marker. How devices tell you that, I am not too sure, but if the devices are tracking it and they are giving an abnormality, it's a good sign that you should consult a cardiologist.
Thanks.
Hello, doctor. I have one question. Basically, wanted to understand what should be the rehab process or probably the post-cardiac arrest process. Okay, if a runner has recently had a cardiac arrest and gone through angioplasty.
You mean not cardiac arrest? You mean heart attack? Myocardial
no. So for me, it was a cardiac arrest like just last month.
Oh, okay.
Okay, and yeah. So I survived probably the cardiac arrest the last month in April. And then I had a blockage in one of the main arteries, around 80%.
Okay.
So like from here on, how should I take it? Like, what should be the journey like?
Okay. So we are happy to have you here now, actually.
Thank you.
And the thing is that recovery is a very individualized process. There cannot be a general prescription for anyone. But it all depends on how severe your condition was and how was the damage or the extent of damage. But the initial start of rehab process happens by the cardiologist. They'll put you through again a stress test, which is called a symptom limited test or a submaximal test, where the ECG or the heart rate is not increased to an extent based on your exertion on the treadmill, but based on your symptoms. So that's how they gradually build it up and tell you that this is the level at which you can exert, which is safe. And then you start from there. So it may start with maybe just a walk or a brisk walk and then a jog. But there the screening process or doing these tests may be more frequent. The cardiologist may actually be assessing you again, putting you through a treadmill at another submaximal test to see how conditioning has changed your heart. Because what happens is that part of your muscle that is damaged in the heart is gone. It's the rest of the heart which will take up the job. And how well it takes up will depend on the time. And that can only be assessed by a repeated testing of your exercise capability. And then, of course, the echocardiography will also tell you there's something called a stress echo, where you're put through a exercise and your heart pumping mechanism is checked. So how your heart is pumping, despite the damage that it has undergone, will also tell how much you can exert. So that's something which has to be very gradual, has to be very smart, and has to be well supervised. That would be my answer.
Got it. Thank you so much.
Yeah. I hope we are okay.
Doctor, one last question. If you have time.
Now I'll start charging consultation fee. Okay.
Yeah.
Okay, please go. Yeah.
So this high blood pressure is definitely one of the symptoms for a cardiac issue. But is the low blood pressure is also a issue for the cardiac issues?
Yes, definitely. You mean on exertion?
No, not on exertion. While resting, if the blood pressure is too low.
Yeah, so low blood pressure is actually not a disease to start with. Actually, a lot of people feel that they have low BP, means 90/60. Some people have that kind of blood pressure and without any symptoms. That may be normal for them. So that's actually not abnormal as long as other tests are okay. If your heart is pumping well and you are asymptomatic, you don't have dizziness when you get up from a sitting position or while you exert, means that blood pressure is okay for you. It may not be abnormal as a disease. But the thing is that your blood pressure should rise while you exert. That's very important. If the blood pressure and the heart rate don't increase when you exert, means there is something wrong. So what is called a blood pressure response to exercise. So people who have this kind of problem, not problem in the sense they feel that they have a low BP, is it normal? Again, a treadmill test before you exert will tell you that yes, your heart baseline blood pressure is this much, but when you are actually exercising, your heart takes on the load, pumps well, and your BP goes up, heart rate goes up, so everything is okay. So that's how we look at it. So if it's no symptoms, BP which is 90/60, not falling during exercise or not increasing without or sort of increasing normally with exercise, all that tells you that it's normal. There's nothing to worry about.
Okay, so in that case, let's say somebody is running at a doing a very intense run, but the heart rate is not high. That also could be a marker. Or that is just that the physiology is already adapted.
Yeah, so there is something called a vagal tone or a parasympathetic tone. So some people this tone is high, they may have a heart rate response which is not so much as it is for others. It may also be a sign of good cardiac conditioning if you have been training regularly, that the heart rate may not increase as much as it does in an untrained person. So as long as it is increasing, it's a good sign. If it is not increasing or is developing an abnormality of rhythm, or the BP is falling on exertion, these are signs that there is something wrong.
Okay. Yeah. Thank you so much, Doctor.
Welcome. I think we'll end here. Or
I have a question, Doc. It's very personal, but my cholesterol is always high, though I keep track of my diet and everything is normal, but the bad cholesterol is always high. So I should keep some precautions? And yeah, my mother has gone. She was the cardiac survivor. So I should keep any precautions while running? Or should...
So high means how high?
I can send it to you right now. I don't have, but it's more than 100. Yeah, it's more than.
Actually, LDL more than 100 is not abnormal, because what has happened is over a period of time, people it was considered high for people who already have a heart disease. So on a routine, for a regular person, LDL more than 100 may not be abnormal or may not require treatment. But yes, it does require follow-up. So as such, we do repeatedly do it and see if it's increasing. But otherwise, just a LDL more than 100 is not abnormal. Just track it. And as far as exercise are concerned, in fact, it may only improve your cholesterol. It may not worsen it. So there's no reason to worry that your LDL is slightly high, so should you exert on it.
All right. Yeah, it has improved from past a year.
Yeah. So it would improve.
It is improving.
Yeah.
But...
Should we end here?